the objectives. Last year I put the page number. I don't know. I didn't check those, so they may not correspond, or they may be close. They may be one off. So I've taught this subject for a while, and when I was at OU, often students didn't have HEPA-Phys before I taught, so that's why there's a big HEPA-Phys section. I just left it in there. I won't ask you those things so you can use them or not, but we'll just kind of go over it to get your mind back in it. So tell me what you learned about IBD.
It's not IBS.
That's very true. I think that's when you're first learning. I need to change it to something else. Mm-hmm. Okay. Tell me about ulcerative colitis. What do you know about it?
Bloody diarrhea.
Superficial what?
Lining on me.
What else? What?
Yeah, just superficial versus Crohn's.
Okay. What else? Give me another fact.
Ulcers and like the distal colon.
Say it again.
Ulcers, like.
Okay. Ulcerative lesions. Is that what you're saying? Okay. All right. What else?
It starts with the rectum and moves this way. There are no skip lesions. Oh, diarrhea. It causes bloody diarrhea.
Bloody diarrhea. Okay. What else?
Descending colon.
Descending colon. Okay. Left-sided. Okay. What else?
Increased risk for colon cancer.
Increased risk for colon cancer. Who's most likely going to walk into your office or your emergency room or your urgent care with these symptoms? Age group.
Over 60.
Young. Teens, 20s for UC. Or you can see the older group, 50s to 70s. So you kind of get two age ranges. What else?
Smoking cessation.
Smoking, okay, interesting. So UC responds to nicotine. So nicotine users usually have lower incidence of UC. So we can use that as an adjunctive therapy. Put them on a patch that will sometimes help. Does not work with Crohn's. All right, anything else you remember about UC? What about Crohn's? What do you know about it? Okay, how are they going to present?
Abdominal pain, right quadrant.
Okay, so bloody diarrhea, weight loss. They have a hard time absorbing nutrients. Sometimes they're malnourished. So what age groups are affected here? It's usually young again. You can have less than 30, greater than 30. Those are kind of your dividing lines when you're looking at high risk versus low risk. Did you all use those terms? High risk Crohn's, low risk Crohn's? Okay, we'll talk about that with regards to drug selection. Okay. What else about Crohn's?
Terminal ileum is frequently.
Mostly terminal ileum. Okay. How is it different from, in terms of what it affects in the GI tract? What's the big difference with Crohn's and UC? Mouth lesions, is that what I heard? Right, so it can affect anywhere in the GI tract. So, but UC stays in the colon. What else did you learn?
You can't just treat topically because the tissue underneath will still be affected and cause cancer.
In which?
Crohn's.
Crohn's, okay.
And you have to be careful using steroids because they might feel good, but there could be more damage, or like the pain might get better, but there could still be underlying damage.
Okay. Anything else? Okay. Very good. So epidemiology, you got a lot of it. Tends to so Crohn's, women more than men. You see men more than women. We talked about the decade frequency listed there. So UC is a lot more frequent. More cases in the country. Crohn's less so. So we don't really know. I think in your lifetime you will see major improvements in it, especially Crohn's. With the biologics that have come along, I think we're just going to get so much better at treating this disease. Of course, they're much more difficult drugs to handle, but much more targeted. We talked about smoking protective NSAIDs. So those can aggravate and make things worse. So when people are having times where their symptoms flare, you want to make sure non-steroidals have been removed or they have stopped taking them. Okay. So this is a problem where the immune system has gone awry, and we've got an imbalance between immune response and adapting to the environment. So these are the comparisons. Surely you all went through these. Oh, I can do the mouse. Are they both on?
Yeah.
Okay, sorry, I didn't know. So constitutional symptoms, much more common with Crohn's than with ulcerative colitis, right? Distribution, you talked about, discontinuous versus continuous, so you need to have them do a colonoscopy, right? Ulcers, rectal involvement, common in UC, rare in Crohn's. Ileal involvement, you got that, very common in Crohn's. Strictures, fistulas, transmural involvement, most of those things you mentioned. Common in Crohn's, not in UC. Crypt abscesses, ulcerative colitis, makes sense with what you described, and then Crohn's, it's rare. And then the appearance is different, cobblestone appearance with Crohn's, not with UC. Okay. So with ulcerative colitis, let's talk about this because this impacts the drugs you use. So where the disease is limited to or affecting will determine our drug. It'll determine our route. So drugs that we can use that get to a specific area will become preferred. So here for proctitis or proctosigmoiditis, we'll use a topical product. Once you get into the transverse colon or the right side, you've got to go with oral because we don't have drugs that, at least topically, will get there. So anytime you're looking at ulcerative colitis, you're looking at where is it? And then that will first determine what type of drug you use. Let's see if there's anything here to... Did y'all talk about classification of severity? Pardon? Okay, well, I'm going to do this because drug-wise, this is how we tend to divide it up, is depending on severity. So this is using, so there's 3 different organizations that I would, if you're interested in this area, keep up with. One is the American College of Gastroenterology, and also the European Colitis and Crohn's organization, and then the Japanese. Each of them, they work collaboratively to put out guidelines. And I would keep a watch of those. I think that these will change in the next few years and how we classify folks. This is mostly done on symptoms. So they're looking at stools per day. And I've laid it out so you can just see the progression from mild to fulminant. Also, blood in the stool with mild may or may not be there, but with the higher or the more severe forms it is. Systemic complications. Some drugs we won't give if they have systemic symptoms. So usually with mild to moderate, they're non-existent or they're low. Severe and fulminant, they're much higher. And then there's SUD rates, so have y'all talked about SUD rate? Mm-hmm. Okay. So something that tells us about the inflammation or inflammatory response in the body. And then their risk for toxic megacolon. Did you all talk about that? So what is a toxic megacolon? Giant colon, dysfunctional, what else? Why do we worry about it?
Sepsis.
Okay, what are they at risk for? Perforation, okay, and perforation will lead to what? Sepsis, peritonitis, okay, and death. So this is really important to pay attention to at the very severe. Okay. With Crohn's, if you look on the very back, did you all talk about the CDAI activity score for Crohn's? Okay, if you look at the very last page and a half, there is a form there. It's the Crohn's Disease Activity Index. Excuse me. And it's one of the ways that you can put a not a number, but you can start to figure out how severe the disease is, and then we can match our drugs to that. So if you look on the back, you see that it goes with abdominal pain, stool pattern, general well-being. These are things the patient's going to fill out. Maybe some of them would be things that you would fill out. Complications that they have, findings of abdominal mass, anemia, weight change. So it takes in a broad objective and subjective data. Then you can see that, in the slide. Okay. So you can see on the slide the score along with diet intolerance. Can they eat what they want? Often they will have dietary problems in tolerating food, to the point where they can't absorb nutrients depending on where the disease is involved, or their ability to just eat. So weight loss is a common problem, and also something you would be monitoring with them. Constitutional symptoms usually occur with the more severe forms, abdominal symptoms as well with more severe. Weight also at the higher severities is going to be more of a problem for them to maintain a weight. Okay, so goals of treatment. So at least from a drug standpoint, the first thing we want to do is we want to induce remission, right? And once we can get them in remission, we want to keep them there. So we're going to have sets of drugs that we use for remission and sets of drugs that we use to maintain. So with management, nutrition is going to be paramount with both of these groups, primarily in Crohn's, because of the extensive, more extensive impact on small intestines and absorption. So we want to be able to make sure that they are absorbing. So getting rid of foods that are making the symptoms worse, with maybe the hope that some of that can be added back in. So again, working with a dietitian will be important. If patients are really malnourished and they need help, then you can look at enteral or parenteral feeding. So do you remember back from nutrition, what's enteral versus parenteral? Okay, tube feeding. Enteral means we're going to put it into the gut and let the gut do the absorption, right? If it's parenteral, what are we going to do? We're going to put it in IV. Do you remember what Peggy Turner told you about enteral versus parenteral? Remember anything? Always use the gut if it's working. Okay. So what did she tell you were important in those enteral feedings that help the gut?
Times where it would be like, you're not feeding time.
Okay, so there was pattern feeding was important because the liver is used to us eating episodically. Okay, that was important. She talked about short-chain fatty acids and the need for them to nourish the gut as well. So we want to keep the gut working. There will be a few times where we'll put the gut at rest, but mostly we want to keep the gut working. So enteral feeds would be important there. And that's probably going to be more of the folks that you're going to admit to the hospital. Surgery. For UC, surgery is curative. So sometimes it comes to that. If they're toxic megacolon, they don't respond to therapy, then they may remove the colon. It's curative. Of course, there's problems that come along with that, but then if they're high risk for cancer, colectomy may be done. as well. With Crohn's, it is not curative. It's too extensive, so we may remove parts of the gut that are cannot be rehabilitated, reformed. That comes along with all kinds of problems from an absorption standpoint. Strictures can happen, adhesions, so let's see. So now we get to drugs. Oh, finally. I can breathe better. Okay. Anything that I said about the pathophys that contradicted. See, I can't escape my training. Yes.
Is the reason that surgery is not curative in Crohn's is because it skips areas?
Yes.
Okay, if there was an area of Crohn's that, like if there's only a small one, could surgery fix it?
Oh,
Like if there's only a small area that wasn't skipped?
I don't think so. It's
They
not.
don't fix the problem like right that I've seen. Crohn's patients they'll have terrible stricture down ileum, and they'll have to take that out so that they can function. But then it'll come back if you don't keep them on immunosuppressive therapy. They'll come back somewhere else usually.
So right now, what we have and our abilities right now with drugs is to affect the inflammation. So we can do that lots of different ways. We can use drugs like salamine. I always think, have you ever seen Ben-Hur? Masala, the big, so every time I think of that drug, I always think of Masala, who's the big villain in the antagonist to the protagonist, Ben-Hur. Okay, that really went off on me.
You actually watch a guy die if you watch that movie.
Yeah.
There's a guy in the background that gets flung from a chariot,
Really?
and he actually dies.
Really?
Yeah.
He says while smiling.
That's such a guy thing. That's what you would remember out of the
Yeah.
movie. Okay. That's
Wow.
Didn't know that.
I heard that they kept that in the movie. It's like a
It wasn't like
it
the
was like
main
real
guy, it was like in the
actor.
background.
Who died? Who
died?
The lead actor in the movie. Anyone?
Oh, the crow.
What movies?
Pardon?
Who's it?
Who's the main character?
Brandon Lee in The Crow. He got shot. And
Oh,
he was
yeah.
actually okay.
Who's the lead actor in Ben-Hur? Nobody?
I've never seen Ben-Hur.
What?
No.
Ben-Hur. See, this is the problem when you start talking about movies from a long time ago, they don't know. They can look it up. He was head of the NRA, spokesman for the NRA. He was Moses. Charlton Heston, that's right. How many of you know who Charlton Heston is?
I've never seen
No.
You've got to watch his movies. Oh my gosh.
Nobody's seen Planet of the Apes?
Yeah.
The original.
The originals. Him in a loincloth. You got to watch it. Why did I? Okay, so the corticosteroids are usually very helpful in induction, but we don't always use them. They're more helpful in Crohn's than they are, or we'll go to it faster in Crohn's than we will in UC. Immunosuppressants, so azathioprine, methotrexate, cyclosporine, 6-mercaptopurine, they are usually used in more advanced disease. Antibiotics have some small role. They used to play a bigger role. They're used now like we would anytime we think someone has an infection. The biologics, so the Tnf Alpha. So usually I've already taught this, so I realized this as I was going through some of this morning. Tnf Alpha is one of the major cytokines in acute phase reactions. So they are big in inflammation. Coming for your edification. You missed the Ben-Hur. He loves Ben-Hur. So we were talking about the Ben-Hur. Oh, because I was talking about mesalamine, and I told him it always makes me think of masala. No, I didn't do that part. But I did tell him that I thought Charlton Heston was hot. cytokine, major for a lot of the big autoimmune diseases, we target it. So acute phase reaction, very broad spectrum, anti-inflammatory. And then the anti-integrin antibodies, we'll talk a little bit about them. And then there's one other class in there, it's the interleukin 12-23s, I think is it. So we'll add those as well as we go through. So lots of biologics are starting to come into the use, especially with Crohn's. So which kind it is, where it's located, and severity is what's going to determine what drugs you use. Okay. There's adjunct therapy, so especially if people don't have constitutional symptoms, then, or if they don't have toxic symptoms, then you can use like an antidiarrheal. You can use antispasmodics to help, or nicotine patches can also be helped to help with symptoms. Okay. All right, so so what I've done is we're going to talk about the drugs, and then we'll talk about how to use them. I have, can you tell they've been highlighted? Yes. Okay. So these are the 5 ASA or 5 amino salicylic acid derivatives. So the oldest one is sulfasalazine, been around a long time. It is a combination of sulfapyridine, which is a sulfa-containing antibiotic, so people who have sulfa allergies are going to be allergic. And mesalamine. So it is really the active moiety. So an old agent, cheap, people can still use it because it's the least expensive. But a lot, if you can afford, moving on to the mesalamine and all the different products there are, those are usually better. They're better tolerated, less side effects. You can use it in sulfa. People have sulfonamide allergies. Okay, let's go down through here. Let's see. Under counseling points, be sure you make a note of this. It impairs folic acid absorption, so if you have someone on it, you have to supplement them. Really important. The preferred is mesalamine. Okay, alternative, better tolerated, a little bit more expensive. It has also been formulated to be delayed release. So if you look down through the products on the next page, you'll see that most of the mesalamine products are going to be in some type of form that will delay their release until they get further down the gut. Okay? Which is one of the problems that we run into, is that the colon, to get things to the colon is hard because lots of things will destroy it, modify it before it can get there. So we're going to see some innovative products when we get to the steroids that will be better delivery products than what we've got currently. So those delayed release products are there to get the drug more to the site of action. Oral agents of this group are usually what we're going to use for a more extensive disease. So once you get beyond the splenic flexure, you're going to have to use an oral agent. So if you're transverse or right side, if you have pancolitis, then you have to use these agents. They also come as topical products. You'll see on the next page, they come as suppositories and enemas that we can use for proctitis and proctitis sigmoiditis. Drug interactions, avoid with agents that will change the pH of the stomach. So antacids, PPIs, H2 antagonists will cause the drug to release early because it's been designed to release at a higher pH. Osalazine and valsalazide are newer products. So they tried to get around some of the problems with delivery. So if you look at osalazine, it is 2 of those mesalamine products put together. And what it relies on is the gut lower down towards the colon to cleave those and to release the mesalamine in the colon. It also comes as a delayed release. Its biggest problem is it causes diarrhea, so it can aggravate the underlying disease. The mesalamine is a prodrug. Again, it is cleaved to mesalamine lower in the gut. So those two products, they're more expensive, they're the newer ones on the market, but if you have somebody who maybe has a partial response to mesalamine, then if you're not full, you could always look at moving them to these products to see if you get more of the drug to the site of action. Overall, fairly well tolerated. Okay, if you look on the next page, page 9, these are the different products. I put some in highlighted so that you'll know representatives. The doses you do not have to know, but I want you to look down there through there and see the approach that is taken. You have induction and you have maintenance. Okay. So inducing remission, these drugs are very good at that, especially in ulcerative colitis. So we have one dose for there, and you'll see usually, what do you see the difference between induction and maintenance meds doses? Induction's higher. As we get further down though, you're going to see this is what's recommended, maybe package insert, but when we get further we'll find that a lot of these, even maintenance doses, are probably on the low end. Usually they need about 3 grams a day for maintenance, most people. Indications, I've showed you where they are indicated for either one or both. We don't use mesalamine as much in Crohn's. It's we have the biologics and the unique steroid delivery systems have taken their place. So we don't use it except in limited cases. So sulfasalazine, azolpidine, been around forever. Mesalamine oral, you'll see Pentasa, controlled release. Lialda, which was one of your prescriptions, delayed and extended release. It's a multi-matrix. So that's a design to dissolve later. You'll see the Canasa is the suppository. I think you have that as a prescription also, and then Roesa. If you look over at the suppositories, these are going to be used more for proctitis or proctosigmoiditis, okay? Because it'll just only affect the rectum. We'll use a higher dose to induce remission, and we'll use a lower dose for maintenance. These are usually, maintenance-wise, are given at bedtime, and we want the patient to retain them as long as they can. We may even use them in pancolitis because patients who have urge to defecate, this will decrease that. So it'll be helpful there as well. Retention enemas, again, when we get to maintenance, we'll use them more at night, and we'll use them on a daily basis. I'll repeat this as we go through treatment. Any questions about those? Okay. I didn't put this one in your handout, but this is really a good slide. You should go back and look at it because for ulcerative colitis, it has the induction drugs, it has the maintenance drugs, and it shows you which parts of the gut. This is a good one to go back and review. Okay. Next page on page 10, this is really an important page. You should learn this one. Because you need to know how far up the gut these drugs will have an effect. So suppositories will only affect about 5 to 8 centimeters of the rectum. Okay. So proctitis is about the only thing they're going to be good at solo treatment, or maybe in combination with another product, depending on how they respond. Or in those pancolitis that we talked about, especially when they have that urge to defecate. Okay. So how much is a centimeter in inches? 1 inch equals 2.54 centimeters, so 2.5. So you're only looking at about 2 to 3 inches of the rectum that those drugs will affect. Okay. but they're very good at it. Now, the enemas will go all the way up to splenic flexure. So you can get proctitis and proctosigmoiditis. All can be affected. The foams, which a lot of people prefer, go about halfway in between. The topicals are always preferred in those situations. They're faster. We usually get better results with them. But you can go to oral, but it's slower and not quite as good. But they are options. Okay. I like this visual. It shows you, it shows you the location of the release of the different drugs. Rowasa and Canesa, they're looking at going from the anus up, and the other ones are looking from the mouth down. This was probably even more helpful when we were using these drugs for Crohn's as well. But you'll see that Ventasa, that's why I like this one, because it affects almost all the gut, small and large intestines. And then the other ones are much better at the colon. So that's why all of these drugs are going to be useful in UC. There's a picture, if you're not familiar with suppositories, down there in the bottom part of the page 11. And a little picture that shows you, again, the area that it's most likely to affect. So proctitis for the suppositories. Questions about those? Okay. Corticosteroids. So very potent, very good, but they're very non-specific. That's why the biologics are so good. They are so targeted. Steroids hit everything. So the problem with steroids is that we can't use them long term. And why is that?
Adverse effects.
It's their adverse effects. So what are the big adverse effects of steroids? Osteoporosis, cataracts,
Weight gain.
immunosuppression. What do they do to blood pressure? Increase. What do they do to glucose? Increase. Bruising, increase. Muscle weakness, weight gain, psychosis. So lots of side effects. We can't use them long term. But they're very good short term, powerful for small amounts of time. Acute management only. We're not going to use them. In the majority of people, we're going to do everything we can to move them off of them if we get to maintenance and chronic. There are some people that have they'll call them steroid dependent. And there's some things that we'll use to even try to decrease the amount of drug they have to use in steroid dependent. So if you look down through there are rectal products. You see quart enema and cortifoam. You've got oral, the prednisone would be a common one we would use. Then you see two others, Intercort and Uceris. These have been specially formulated to release the drug at specific points in the gut. For Uceris, you can think ulcerative colitis, UC. This one is a multi-matrix. It's designed to release into the colon. Let me see if I brought it up. No, that may be as much as I can find. Okay. So if you look over, this one we use for about 8 weeks. Most of the time, most patients you can induce remission quickly. We usually would like to see it within a few days to a couple of weeks. Then that last 6 weeks or so is for the healing of the affected gut. So this one we'll use about 8 weeks. Even though it is a release in a certain part of the gut, we still can get systemic effects. So we can still get adrenal suppression. If we use it long term, we can see the steroid side effects. There are some instances where people will use them up to 6 months, but the data beyond that doesn't exist that would say it's worth the risk versus the benefit. The Entacort is one that is for Crohn's disease. So you see that it is a controlled release at the ileum. So this is a really good one. This is going to be our go-to for remission in Crohn's, especially in mild to moderate disease. It's another one where we use it for about 8 to 12 weeks to induce remission. So when you think steroids, think acute phase remission and induction. We use the IVs usually in people who have more fulminant or severe disease that have been admitted to the hospital. Okay. If you look it up at the top, there's your adverse effects. The other is warn people, don't stop it abruptly. Why is that? Why do we not want them to stop it? Well, what is withdrawal? They're going to have symptoms of withdrawal? Are they dependent on it? So
Hypertension, their blood pressure.
Yeah, they're not producing enough of the hormones in their own body.
okay, so those, so that hormone, so the steroids that you produce naturally are going to have a negative feedback loop, and so when you put a lot of steroids from exogenous administration, it suppresses the adrenal gland. They're like, I don't need to make any. Okay, it cannot ramp up quickly. So if you stop steroids quickly, then their adrenal glands cannot respond. If you put a stress on them, then they can die. So you cannot stop abruptly because of the adrenal suppression. So that's why we taper off. One of the reasons why we taper off. One is because disease can flare, but another is to allow the adrenal glands to start remaking their own steroids so that you can deal with whatever stresses come along. Okay. Okay, the immunosuppressants. These are more going to be used in Crohn's. We do use them in the more advanced or severe cases of ulcerative colitis. The problem with them is that they take a long time to exert effect. So it can take them 6 months. So we often will use steroids to be bridges between the time that we start these drugs and when they're fully effective. So the first two, azathioprine and 6-mercaptopurine, are very similar drugs. They interfere with DNA building. So they're purine substitutes. So they're like a false metabolite. You stick them in the DNA and the DNA can't do anything anymore because you put a rogue purine base in the DNA. So it will stop that production. So these are, those two are very similar. Their adverse effects are major. So you'll see T-cell lymphoma, neutropenia, hepatotoxicity, nephrotoxicity, myelosuppression. They're big myelosuppressive agents, so those cell lines are all at risk. So we start low and we titrate them up. Usually we use very low doses and we can reduce the amount of steroid they need. So if people are steroid dependent, we use these, we can get away with a much lower dose of the corticosteroid if we had to continue to use it. Cyclosporine is a drug that we usually just use it initially, especially in the more fulminant stages of UC or Crohn's. So it's very good at inducing remission, but you cannot use it long term. It's an old drug that we used when we would transplant people to keep their bodies from rejecting an organ. Methotrexate, when we get to RA, we'll find out it's one of our standard foundation drugs. Here, it's usually more of a last resort. It can be used in low doses over long periods of time, but it isn't our usual go-to when it comes to the immunosuppressants. Antibiotics, the two that would most commonly be used if there's infections in that gut would be a fluoroquinolone and metronidazole. That's all I'm going to say about those. The Tnf Alpha, there are 3 of them that are approved and used for mostly for Crohn's. So infliximab, Remicade, been around a long time. Adalimumab, which is Humira, and then sertolizumab, Cimzia. If you look over there, you'll see that Remicade is a chimeric antibody. So what does that mean? What's the chimeric? Mouse and human. So because it is more of a mix, what would you expect what's the immune system going to do with it? It's going to make more antibodies against it. It will be a more immunogenic drug. So that's one of the problems with Remicade is that the body produces antibodies and reduces its efficacy. Humira is a fully human. So we don't make those antibodies. So there's more go-to to the Humira because of that. And then Cimzia is a humanized, less likely. So the more likely drug that you're going to have trouble with antibodies is Remicade, then the Cimzia, and then the Humira. So again, these drugs are all TNF alpha inhibitors. One of the big things, and we will go through these in much greater detail when we get to RA, but they activate TB, HIV. So ruling those out, TB you have to rule out before you use these drugs. They're also fairly myelosuppressive, so they can knock out platelets and red blood cells. The likelihood of producing tumors or coming up with tumors, especially those lymphomas, is common. Okay. The anti-integrin antibodies, these are most exclusively used in Crohn's. These are usually far down the line. These are going to be in your high-risk, severe patients that you would use these. So if they didn't respond to the steroids and the other biologics, the Tnf Alpha, then you would look at this class. Questions? Okay. Since this is a good break, before we start talking about treatment using these drugs, let's take a break. We'll come back in about 10 minutes and then we'll finish up. So we should get done a little early today.
Oh, I'm hungry. I'm not hungry. I didn't bring my lunch.
Yeah, that's the rest of the day.
Is this still on?
But I don't have my